Welcome back. Moving to the next session for today. It is about current strategies in managing ILD. To chair the session, I welcome Professor Subodh Kumar, Department of Pulmonary Medicine, AIMS Gorakhpur, to honor the session. I call upon Dr. Abhishek Tandon, Consultant Pulmonologist, Medanta Hospitals, Lucknow, to chair the session. Next, I invite Dr. Nirupam Prakash, Secretary of API, Lucknow branch. And I invite Dr. Mohammad Amir, Consultant Pulmonologist from Lucknow, to chair the session. I call upon Dr. A.K. Singh, Consultant Pulmonologist in Regency Hospital, Kanpur, to the dais to chair the session. Setting the tone for today's session, I invite our first speaker of the session, Professor Naveen Dutt, Professor, Department of Pulmonary Medicine, AIMS Jodhpur, to share his valuable insights on management of hypersensitivity pneumonitis. And I request the chairpersons to kindly introduce the speaker and preside over the session.
Thank you, Almajid. Dr. Naveen Dutt is professor and head of Department of Pulmonary Medicine at AIMS Jodhpur. He did graduation from PGMI Rohtak and post-graduation from Government Medical College Hospital, Chandigarh. He was honored as ILD Fellowship in the European Respiratory Society. He is known for groundbreaking research and nearly 150 publications in the field. His prime area of interest is interstitial lung disease, intervention pulmonology, and sleep medicine. Dr. Naveen, please.
Uh, First of all, I would like to thank the organizers and the chairperson for this opportunity. So straight away we start with the presentation. My topic is the management of hypersensitivity pneumonitis. So uh, a significant part has been covered by Dr. Mansi. So I'll try to focus on the other aspects which has not already been covered. So we all know that HP is an immune-mediated ILD. There are susceptible individuals either due to environment or due to genetics. So when they inhale antigen, they develop aberrant immune response, which involves T cells and gradually the B cells also. Then they develop the parenchymal as well as peribronchial inflammation and fibrosis. So the parenchymal inflammation happens in all the ILDs, but the peribronchial inflammation and the small airway obstruction, it happens in a limited number of ILDs. So this part is very important when we want to differentiate HP from other ILDs. When to suspect? So HP should be suspected in all the cases of ILD. Not only HP, all the reversible ILDs, they have to be suspected in every patient of ILD. But in a country like India, where the HP is most likely the most predominant form of ILD, we need to suspect in every patient. And when do we suspect it more? When there is known exposure, or IgG is positive, or radiology is suggestive of HP. So first of all, the diagnosis of HP. So like any other ILD, the gold standard for diagnosis of ILD is MDD. For the diagnosis of HP in a MDD, there are three major components of diagnosis, three major domains: the exposure identification, radiology, and the BAL. If diagnosis is not made non-invasively, then we might need a biopsy, and then can again review the diagnosis. So exposure identification can be, we can find the exposure in a history, maybe someone was feeding pigeons, or with the help of a test. Normally we are doing the IgGs. So if IgG against specific antigen is positive, then we presume that there is exposure. So these are different scenarios in which exposure to antigen can be there, and we should be suspecting that this might be causing ILD. The pigeon feeding, the cleaning an area infested with the droppings and the feathers of the birds and pigeons. certain birds, not only pigeons like doves, lovebirds. We had a couple who both developed ILD after bringing in the pair of lovebirds. And even the feathery pillows and mattresses can also cause ILD, the HP. Farming and gardening, exposure to decaying organic material, manure, uh, exposure to wood peeling and other exposure related to wood cutting, the exposure to wood dust, carpenters, they all can develop ILD. Similarly, the furniture which has been destroyed by water, the fungus can grow in this area and can cause HP. The damp and humid area, they allow the growth of bacteria as well as fungus. So these areas like the damp wall or water damaged carpet, the swimming pools, the dripping taps, the infested ventilation system, maybe the cooler system, even AC, all these can lead to HP. Uh, the the flour mill, the bakery work, or even the metal working fluid. In certain industry, we use metal working fluid to keep the machine cool and lubricated. So even mycobacteria, they can grow in this metal working fluid and they can be inhaled by the workers. So all these can cause ILD, the HP. So when we are looking for an exposure in a patient of ILD, we need to take a detailed history of exposure at home, workplace, and it can be a place of hobby. Someone playing in a badminton court where the pigeons they come and they are droppings, it can cause ILD. We can use questionnaire, but we have seen it is difficult to use in a clinical scenario. So normally we take random history only, depending on the common scenarios in the geographical area. Similarly, there are tests for exposure. Most commonly, we use specific IgGs. There are several methods: immunocap, ELISA, precipitins. So if the test is positive, we presume that the person is exposed to the antigen. Now, radiology is the most important domain when we are trying to diagnose HP. So there are two guidelines, one ATS guideline and second chest guideline. So both emphasize the radiology as the most important part of the diagnosis. Both the guidelines, they divide the HP into fibrotic and non-fibrotic. Before that, we used to divide into acute, subacute, and chronic. And they divide fibrotic and non-fibrotic. Now further, they divide the HP into typical, compatible, and indeterminate on the basis of radiology. Typical is when the CT is very much suggestive of HP. Compatible when it's not very much suggestive, but still the picture is compatible with the HP. Indeterminate when it's neither typical nor compatible. So all the patients of HP will not have typical HP only radiologically. They can have compatible, indeterminate. It might present as NSIP or UIP also. So this is for radiological classification for the purpose of diagnosis. So these two guidelines, the ACCP and CHEST, they both are similar when we look at the radiology part. But the ACCP guideline is slightly more lenient in making the diagnosis of typical HP. And also this study shows that the CHEST guideline has better accuracy and negative predictive value when we are working in a high prevalence area. So if we look at Indian scenario, I think even practically also the CHEST guidelines, they are easier to apply. So their accuracy and negative predictive value, they are better. So when we are looking at radiology, there are few important things when we are looking at the radiology of ILD patient. One, try to use console in each and every patient, because without console, it is difficult to look at. Normally in CT, we get the axial planes, and rest of the planes, they are difficult to see. If you want to see the craniocaudal distribution and even the diagnosis of PPFE is not possible if we are not using console. So always try the patient should be bringing his CD and we should be diagnosing it on CT scan only. When we are looking at console, we should be making four things. We should be ensuring four things. One, the CT should be in full inspiration. Slice thickness should be less than 1 millimeter. No contrast. Normally, for any ILD, we need a CT without contrast. One scenario is when patient is worsening, acute worsening. In this scenario, the acute pulmonary embolism is also one of the differential. So in such a scenario, we should be doing HRCT first and then we should be doing the CTPA. So when we are comparing two CTs for progression, at that time we should be ensuring that window width setting we are using in console should be same. Otherwise, one area can look whiter. We might mistook as ground glass opacity. Expiratory film, we don't use it. Even we do a regular MDD with the Royal Brompton. They also don't uh, uh, require expiratory CT for the diagnosis. So there is some issue of the mosaic attenuation and the air trapping on expiratory. But in most of the cases, the expiratory CT is not required. But wherever you feel you need it, you can do it. So this is the radiology of HP. So there are three important things when we look at the radiology of HP. One is distribution. Second is parenchymal opacity. Third is airway involvement. So we should be looking for focus things when we are looking for HP. We want to rule out HP or SCT. So distribution is both axial and craniocaudal, sagittal section, the coronal section. So that is why we should be using console. So distribution is not important in a patient of non-fibrotic HP because it is diffuse, both axially and craniocaudally. But when we are trying to diagnose fibrotic HP, then there is some role of the distribution of ILD, not much, only when we are trying to differentiate it from IPF. The parenchymal opacity and airway involvement. If they both are, then radiologically there is high probability of HP and we'll label it as typical HP on radiologically. So here we can see this axially, this is peripheral ILD, this is the mid-lung predominant. On radiology, if there is parenchymal involvement and airway involvement, more specific because these commonly don't have this mid lung predominance. So when we try to diagnose